Hello. My patient this week is a 32-year-old male admitted to our hospital for detox from heroin and fentanyl. Use is IV. Patient's last use was on 2/5/21. He has a history of taking Suboxone since last July, and his last use was 3 days ago. Patient has a treatment history recently at Midwest for about a week in January of this year. Upon admission, patient was positive for amphetamines and benzodiazepines. He reports using Xanax 1 to 2 milligrams without a prescription about weekly. His last use was on the 5th. Patient also reports a use of Adderall about weekly, and last use was about a week ago. And he also reports using heroin or fentanyl for about the past 5 years. And his recent use of fentanyl did not show up on the drug screen because, unlike heroin, it is not detectable through the drug screens. Currently, he reports his mood, medication tolerance, sleep, and appetite as fine. And when trying to press further and ask how much he ate, he rolled over, super agitated, rolled his eyes at me, said a lot, and rolled back over to sleep. Like, okay, buddy, I'll let you rest. He's actively going through withdrawal, so using clinical judgment of pushing further with questions being not therapeutic. So I made a judgment call to let him rest instead of pushing further. But upon follow up later, I was able to get some more information. Access 2, no evidence of a personality disorder. Access 3, medical history includes detox and withdrawal about 3 times last year, 2017, 19, and then earlier this year. Additionally, his current labs, ALT of 166, normals 5 to 52, AST of 104, normals 13 to 39, and a GGT of 160, normal is 9 to 64. Uh, Access 4 patient does report being homeless and having difficulty finding employment. He states that he has not been able to pass drug tests in years and has no desire to get a job. He reports his income to support his drug habit comes from theft and selling drugs. I gave him GAF score 50, serious symptoms and impairment in social and occupational functioning. Possible differential diagnosis, opiate, well, most likely would be a differential diagnosis, opiate use disorder. The criteria here: opiates taken often in larger amounts and over a longer period of time than intended. Desire to cut down. A great deal of time spent in activities to obtain the drug. Cravings. Recurrent opiate use and failure to fulfill obligations such as work, school, or home. And then continued opiate use despite having social issues. And moving on to ideological factors, patient reports having an addiction issue since he was young. Parents were both addicts and was around drug use growing up. He feels that he was exposed to this addictive personality trait from his parents, and it was reinforced by learned behaviors. Um, what I would do for treatment moving forward: he's currently being prescribed Suboxone, and providing education about Suboxone important to relay that this is not a maintenance drug, is meant to be used short term to help patients get through withdrawal. Most insurances only cover this drug for a few days. Further education, it can include that this medication is a partial opiate receptor blocker, and it only goes to a certain percentage. It has a ceiling that it does not go past, which is nice because there's no risk for side effects like respiratory depression. Is also considered very sticky, and it attaches well to receptors, and this helps flush out the other crap in your system. Additionally, education around coping with distress is important for patients like this because opiates are very effective at eliminating subjective experience of distress. After a while, the individual is less and less tolerable of distress because of this. So when going through withdrawal, which is a very stressful situation, and along with no longer having the drug and having daily stress, the patient may require further psychological support, and possibly like by an outpatient treatment, outpatient practitioner. So I would be giving information for follow up as well. And that is my report. Thank you.